a little bit about myself. Healthcare is really challenging and it's hard. And there's usually a very important driver of why we do what we do. So I have pretty humble beginnings. I shared this last time we did this too, but I think it gives a little bit of context. But pretty humble beginnings, went to med school in India, moved to the States, did residency in internal medicine at UCLA. And then I worked as a hospitalist. Hospitalist is like an internal medicine doctor working inside a hospital setting most of the time. I was working at Loma Linda, and while that time I became very interested in critical care and pulmonary medicine. So they luckily took me as a pulmonary critical care fellow. And as a pulmonary fellow, we saw a lot of sleep apnea patients, and that basically unlocked it gave me some insights into how important sleep is for our human physiology, how broken the system is. And with that mindset and passion, I applied to sleep medicine fellowship, and I had the opportunity to go to Harvard, was at Beth Israel Deaconess Medical Center, MGH, Boston Children's, and had the opportunity to work with the most brilliant minds in the country. And ever since then, the idea of Empower Sleep has been, how do we deliver Harvard grade sleep care online? So this is a quote that I love sharing. I'll read it out loud. And it's from a very famous researcher. Solomon, maybe you've seen this, researching in the sleep space, but if sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary process has ever made. And it's so powerful because evolution does not make mistakes. And if the human body is designed to sleep for, somewhere between, at least adults, 7 to 9 hours in the evening time during the hours of darkness, there has to be a very strong biologic reason for that, because it's not conducive to doing anything else. We're not reproducing, we're not eating, we're exposing ourselves to threat. So there has to be a very strong reason that evolution has designed us to do this. And for those of you who, are coming in for the first time, I love using this analogy here. And, sometimes people will say that this is, a car. Some people will say it's a parked car. But to the trained eye, many of you guys, you will say, okay, like I see this green light is on and this is a charging car. And if I told you that not only that this car is charging, but at that same time, it's getting a new layer of rubber over the wheels, something is cleaning out the windshield wiper fluid, someone is vacuuming the inside of the car seats, someone is cleaning out the trunk, the transmission fluid is although it's electric, but you get the idea that the fluid is being exchanged. Although we have the technology to charge the car, we do not have the technology for all of these other processes to happen. But the human body is such that when the human body is sleeping, it is far more than just charging. During sleep, our brain, the blood flow to our brain is at its peak. Beta amyloid plaques that are precursors to Alzheimer's dementia is being filtered. During sleep, something happens to our cardiovascular function where the amount of blood flow is a lot less. During sleep, in our GI tract, peristalsis slows down. Urine production, flow to the kidney slows down. So during sleep, the biologic functions of our body shift from what was happening during the biologic day to what is now happening to the biologic night. So what I'm inviting you to think of is when somebody is sleeping, we are not just trying to fix their breathing or fix their insomnia to help them sleep, but rather we are trying to fix all of those physiologic processes that are designed just for sleep. And growth hormone, a lot of the athletes rave about this, of why LeBron James needs to get his X number of hours of sleep at a certain period of time. That's because, for example, growth hormone, it peaks only during the hours of sleep. If somebody sleeps during the day, during their biologic day, they will not have that same peak of growth hormone as if they sleep during the biologic night. So the timing of sleep, the duration of sleep is all very important for all of the biologic processes that need to happen for a healthy human body. Last time we talked about why sleep is important, some of the functions of sleep. Today, I would like to talk a little bit about, how sleep is measured. We'll talk about a little bit of the different kinds of sleep tests on the market. We'll talk about single night versus multi-night testing. And we'll have a little discussion about how can one personalize sleep care using objective data. So how is sleep measured, right? our nervous system is broken down into the central nervous, and to understand this, I'm breaking it down this way. But our nervous system is broken down to the central nervous system and our peripheral nervous system. And the peripheral is broken down into somatic and autonomic, the autonomic being completely involuntary, automatic, breathing, heart rate, all of these things, somatic being all of like skeletal muscle, all of the voluntary things. How the sympathetic and parasympathetic nervous systems play, how they interact, allows us to understand what is happening to someone's autonomic nervous system across a 24-hour period. So when we look at sleep, we can measure sleep either by directly measuring it on the cortex and by looking at what is happening to the central nervous system, or we can measure sleep by looking at what's happening to the autonomic nervous system. So home sleep tests, they typically look at the autonomic nervous system to estimate parameters of sleep, while traditional in-lab sleep tests measure sleep directly from the cortex. So this is an example of an in-lab sleep study. A person is hooked up from head to toe, usually probably getting the worst sleep of their life, hooked up like a lab rat. And during that time, we are measuring not only measures of sleep, but we're measuring cardiovascular, respiratory, muscle tone, chin tone, oximetry, all of these different variables, but sleep is measured directly at the cortex. And based off of the different waves, one can understand what stage of sleep somebody might be in. So during awake, the frequency is very fast. The brain frequencies are much faster than if they are in very deep sleep. So you have awake, you have stage 1, 2, 3, and as one gets into deeper and deeper and deeper sleep, the waves start to slow down. These oscillations start to slow down. And the very interesting thing is being awake is very similar to being in REM sleep. So during REM sleep, the brain is metabolically very active and it looks almost the same. So, how is sleep measured? One can either measure it directly from the cortex at a central nervous system level, or a lot of these home sleep tests, they measure sleep from looking at the autonomic nervous system. And one of them, and many of you are familiar with this, is a WatchPat sleep test and Night Owl. They basically look at what is happening to the peripheral arterial tone of somebody, and then indirectly looking at what is happening to the autonomic nervous system during the hours of sleep. Other sleep tests are sometimes, like for example, this ResMed device is actually not measuring sleep. It is measuring breathing, assuming somebody is sleeping. These Aries devices, anything that measures sleep directly, this can measure sleep and it measures breathing. So these are more of a flow-based test. They are directly measuring flow. How is one breathing? How is their chest moving? How is the abdomen moving? What is happening to their heart rate? What is happening to their oxygenation during sleep? This is a type of home sleep test. In lab sleep studies, we are measuring sleep directly from the cortex. And then we have the sleep image device, which is actually an oximeter, but powered by the sleep image system that is looking at what's called cardiopulmonary coupling, CPC. And it is looking at the sympathetic, parasympathetic system by looking at what is happening to the heart rate and what is happening to oxygenation and breathing, to then get a reflection of how well is somebody sleeping and what is happening to their physiology during sleep. And there's a whole bunch of tests coming out in the market, right? Like the idea is we want to figure out as many ways as possible to understand how can we estimate somebody's sleep. So Sunrise is a tool coming to market. It just got FDA approved. It's a little patch that goes on the chin and it measures the movements of the chin and the jaw, and it has an oximeter built into it. And you can see based off of chin movements, like that surrogate, one can estimate what stage of sleep, what kind of sleep, and what is happening to them. And then you have these devices like Whisper that have patches that look at breathing, and based off of that, they can understand what is happening to somebody's sleep. So the idea is not to get fixated on the kind of technology, but to rather understand what's the foundation of that technology, how does it work, so then that test can be used and understood and applied to your patients, so you can come up with a very personalized care plan. One of the questions that had come up in the post was, why single night test versus multi-night test? And, we've all have noted, at least I can speak for myself, that sometimes I sleep well, sometimes I may not sleep as well. Sometimes people have symptoms of insomnia, sometimes they don't. So there's we all are aware of the night to night variability that happens in our sleep. So why is it that when we do a sleep test, we only do a single night of sleep test? Why is it that you can only get one night of data and you're forced to make a decision? Researchers more recently have started looking at this, and one of the larger trials came out in 2020 or 2022. It was published in Chest. They had about 10,000 or 10,500 patients. And what they identified was about 90 some odd patients who had no sleep apnea. They stay in the category of sleep apnea. 80 some odd patients who had severe sleep apnea, they stayed in the category of severe sleep apnea. But a big chunk of patients would have a lot of variation in their night-to-night burden of sleep apnea, fitting this picture that almost 20% of patients can be misclassified, whether a mild person could be categorized as severe or a mild person can be categorized as moderate can be categorized as mild, or between moderate and severe obstructive sleep apnea. So getting more data helps us understand what is happening to someone's sleep across time. It allows us to understand how are different interventions working. If somebody is sleeping with a wedge, or if they're sleeping with a chin strap or a lip tape, or even a prescription therapeutic like a CPAP machine or a dental appliance, multi-night testing really allows us to understand what's happening to someone's breathing and physiology and sleep during the night. And when it comes to how do we personalize, or how does anybody personalize sleep care? It's not just about the test. It has to come down to what is the patient's story? What are the signs that one is observing or on their exam? What are some of the symptoms that somebody is endorsing when you have that conversation with them? What are some of the comorbidities that they have? Do they have AFib? Do they have heart failure? Do they have COPD? Do they have emphysema? Do they have asthma? Do they have a neuromuscular disorder? Do they have a diaphragmatic paralysis? There's all of these things that one needs to know, because if somebody has mild sleep apnea, but they have AFib and hypertension and heart failure, I would be much more compelled to encourage this patient to let's pursue a treatment, as compared to if they have relatively asymptomatic mild sleep apnea and they don't have any of those comorbidities. So understanding what comorbidities people have, it becomes very important in coming up with a personalized care plan. The craniofacial anatomy plays a big role in this. Airway, our cranium sets the foundation of our nasal cavity and our oral cavity. So if the craniofacial development is hypoplastic in any way, shape, or form, one may not be able to breathe as well as if they did not have any of those problems. Down syndrome is a great example of this. Children who have Down syndromes, the prevalence of sleep apnea or any sleep disorders is north of 60%, and sometimes even higher. And then it comes down to the sleep data. The apnea hypopnea index, especially I know there's a lot of mostly dentists here, but in the context of sleep, it's very easy to just look at what's called this apnea hypopnea index, which is a way of measuring how many times per hour does one stop breathing. But other things to look at that are extremely important is what is happening to their quality of sleep. How much stable sleep do they have? If they have hypoxia, what is the burden of hypoxia? Are they a sound sleeper or not? And you can look at their graph of activity over the course of the night. And I think primary care and cardiologists are a very good example of this. When somebody goes to a clinic and they check their blood pressure, fixing hypertension is very different than fixing someone's cardiovascular health. So this idea of fixing their apnea index is very different than fixing somebody's overall sleep health. So I just want to invite you guys into thinking about it this way. The idea, one is obviously you want to fix their blood pressure, but the goal is to prevent them from dying, prevent them from having a heart attack, stroke, or any of that stuff. So we really want to improve their cardiovascular health. And in sleep, in addition to fixing, if they have sleep apnea, you want to address the sleep apnea, but the goal is really helping them improve their sleep health so they can live a much healthier life. And the other things that also influence, how to personalize their sleep care, what else have they tried in the past? Have they tried CPAP? Have they tried weight loss? Have they tried a dental appliance? Have they tried a wedge, lip tape, chin strap? There's all of these, both prescription and non-prescription therapeutics out there. What all have they tried? So that allows us to understand what else can be done. There was a request to look at some examples. I have 3 examples, and I'm happy to do more, given that hopefully we'll have some time. This is my sleep test, and this is a sleep test using a sleep image technology. And this is so the report of sleep image comes in a 2-page output. This is the first page. This is the second page. On the second page, there is this chart called the spectrogram. This is basically a sort of a one-pager of what is happening to someone's physiology during sleep. So let's go through this one by one. So on the very bottom here, we have time 2200 to about 6 a.m. The row above that is the quality of the signal. As you can see here, that here the signal quality is green, but there are periods of red. All that means is that there was not good data collection at that time. And I think I was probably sleeping next to my kids and maybe the ring came off or something of that nature happened. It's something to consider as one is, because these numbers are a computation of this raw data. So if the data is of poor quality, these numbers may not be as accurate. So we have our signal and then we have our SpO2. SpO2 should be above the mid 90s the entire night. There are these brief events happening. I don't know if they're real or not, but it could be just from movement also. The graph above that is a graph of activity. It's called actigraphy. These are bursts of movement. This is sound sleep. This is some movement, and you can start seeing a pattern that there was a lot more movement in the latter half of the night as compared to the earlier half of the night. And this is normal. People have much deeper sleep in the first half of the night as compared to the latter half of the night. And then up here is what's called the spectrogram. This is basically looking at the frequency of coupling on the y-axis and the stages of time on the x-axis, and we can start estimating different stages of sleep. So these dark blue mountains are deep sleep, and this is very healthy deep sleep. The light blue mountains are light sleep, and the orange is a mix of REM and wakefulness. As you probably remember from the earlier slides that I showed, when measuring sleep directly at the cortex, REM and wake look very similar. And when we measure sleep from the autonomic nervous system, REM and sleep look very similar as well. So it gets categorized the same way. If there is the absence of movement, it will be REM. If there is a lot of movement, it will be categorized as awake. So this is a healthy spectrogram, a lot of deep sleep. And then here are the numbers. Overall quality of sleep is good. So the first box here is the sleep quality. The second box here is the opportunity for sleep. Third box here is some of the sleep apnea parameters. And then the fourth box here is the pathology for sleep. So overall quality of sleep is preserved. The opportunity of sleep is good. I fell asleep pretty quickly. The recorder was on for a pretty decent number of time. These are some of the sleep apnea indicators. This one is mildly elevated, but typically I don't have mild elevation in my apnea indices. And then this is looking for any kind of pathology of sleep. And there's no fragmentation. There's no periodicity. So this is overall very, very healthy sleep. Other things that one sees on here, and I won't spend too much time, is what is happening to the oxygenation over the course of the night. What is the cumulative time with an SpO2 less than 90, less than 88, less than 80%? We have some more details on the different sleep apnea indicators, looking at the AHIs, looking at the RDI, which is a respiratory disturbance index, and looking at the ODI, which is the oxygen desaturation index. And we have some characterization here of the different kinds of drops in oxygen, how long they last, and what is happening to the heart rate during sleep. So that was a relatively normal one. And this is a pathologic one. And I'm not going to call out on anybody, but I'll just walk through this. This one thing that was very obvious and visual is that there is no deep sleep, right? There is little to no stable sleep. And stable sleep is extremely important for healthy physiology. It's only during stable sleep where the brain has the highest amount of blood flow, where molecules like adenosine get filtered out. It's during stable sleep where beta amyloid plaques are cleansed out. So stable sleep is extremely important for the health of our brain. It's only during stable sleep that blood pressure drops during the night. It's only during stable sleep that heart rate drops during the night. And these are all very important things for a healthy cardiovascular system. So this person has no stable sleep. They have a ton of fragmentation all across the night. Their periodicity values are very high. Periodicity sort of refers to central sleep apnea. Their cyclic variation heart rate is very high. And what you can start seeing here is that their oxygenation, it starts off in the mid 80s. That's horrible. And during the course of the night, it drops even below what can be measured. So what should have been a straight line above the mid 90s is this sort of persistently low oxygenation over the course of the night. And if one starts counting the number of times this person stops breathing, the computed values are about 90 times an hour. So this person had 90 times an hour they stopped breathing. Their sleep quality is horrible. It's in the low double digits. The fragmentation is very high. The overall burden of sustained hypoxia is almost 7 hours. So this is an example of somebody who has extremely severe hypoxic obstructive sleep apnea. Here's another example. It's important for us clinicians to be aware of the different technologies out there. This is a WatchPat sleep study. This is I think a 60-ish-year-old gentleman that was referred to us for snoring. And this is also usually a 2 or 3 page report, but what is the most useful are these graphs here. And what you can see here, just by looking at the oxygenation, this person started off, this number is 100, this is 90, 80, and so forth. And they started off in the mid 90s, and you can see how their oxygenation dropped almost down to the mid 60s. It would come up, but it still is a sustained low oxygenation. And if you count the number of times that this is happening to this individual, here's the, again, AHI, the apnea hypopnea index, almost 90 some odd times an hour. The other thing that we see here is there is not any significant dipping in heart rate. The architecture of sleep is abnormal. This is a pathologic architecture of sleep, and they have a lot of sustained hypoxia with an oxygenation less than 90% for a sustained period of about 266 minutes. So, I mean, this hypoxia it correlates with cardiac morbidity more than the apnea hypopnea index does. So this person needs to be started on treatment ASAP. The RDI, so it depends what test one is using to estimate RDI. The RDI from an in-lab sleep test is different than the RDI from, for example, I'll just use the example of a sleep image sleep test. For the audience here that's not familiar with what RDI stands for, RDI is the respiratory disturbance index. For example, some people, they may stop breathing for 10 seconds or more, and they may potentially drop their oxygenation. That would be considered like an apnea, or what's called a hypopnea, a reduction in breathing that resulted in a drop in oxygenation. In some people, what can also happen is the difficulty with breathing, that they are breathing so hard that they wake themselves up trying to breathe. So that is called a respiratory effort-related arousal. The other term for that is called a RERA. And in a lab, one can directly measure arousals at the cortex. With a home sleep test, one is measuring arousals with the change in frequency that is happening in the cardiopulmonary coupling. So what happens is the RDI on a sleep image sleep test is actually an arousal index more than it is a respiratory disturbance index. So if I'm in pain, my RDI, which is presumably the respiratory disturbance index, will be falsely elevated. It will be elevated truly because I'm waking up, I am having more arousals, but it is not necessarily respiratory in origin. That makes sense. So RDIs is useful. For example, if I see somebody who has excellent sleep and they tell me, hey, I have witness apneas, I snore very loud, and their RDI is elevated, to me, that is okay. This is probably true elevation, and this is respiratory in origin. But if someone tells me that they don't snore, they think that they sleep well, there's no witness apneas, the RDI is high, then I'm looking for symptoms. Hey, do you have chronic pain? Do you have chronic anxiety? Do you have restless legs? Because in that situation, that RDI, because it's more of it's just a marker of arousals over the course of the night. My job becomes to be a better historian to understand what are other things that can be causing this person to wake up very easily over the course of the night. So the first thing to understand is there will always be variation. If we know that there is night-to-night variation in someone's sleep, then there will be even more variation when we use different tools to measure their sleep. So that's the first thing to be aware of. As long as the numbers are similar, that's okay. Like, we've done a lot of oral appliance titrations where what I typically do is I'll look at what's the cluster of their sleep over across a week with maybe 7 to 10 nights of testing with a certain setting. And then I'll look at their sleep across, 7 to 10 nights of sleep with a different setting. What I've started to do is I look at how does this cluster of sleep compare to this cluster of sleep, rather than how does this value of sleep compare to this value of sleep, because the night-to-night variability is so high that it's extremely hard to ignore. So what I typically tell patients, one is medical grade devices. They've gone through the FDA in terms of their precision and their accuracy. That's number one. So the data is going to be far better there than any consumer grade wearable. And then there's also a lot of night to night variability. And how one is measuring sleep is different with different tools. So there is going to be some level of variability that happens that is inter-tool variability. So this is normal. So what you're describing, that there is some variation, that is normal. But the thing to be mindful of is if on one test, let's say the burden of hypoxia is X, on the other test, the burden of hypoxia is like 50% more, there's something is wrong. But if the difference is say 10%, I think that's just an inter-tool, inter-night variability. So these consumer grade wearables, they've done a good job at driving awareness of like that sleep is important, because they give people insights on a daily basis of what's happening. They also do a reasonably good job at identifying sleep and wake. If you look at the sleep architecture and the intercorrelation, the sleep stage correlation coefficients, the sleep stage correlation is not that great. So the stages of sleep is something it's useful information to have, but it's not going to be as good as like an in-lab sleep test or a medical grade sleep test. And the other thing that is very useful from these consumer grade wearables is that if somebody persistently has poor sleep on their consumer grade wearable, usually, at least it's a good starting point to say, okay, maybe I should get a medical grade sleep test to understand if there's actually something going on or not. So I think they are very useful, but I would not necessarily use them to titrate a therapeutic modality. Like I wouldn't necessarily prescribe somebody Ambien and see what happens to their Whoop and Aura Ring. I would rather do that with Sleep Image or Sunrise or Westport, any of these more of these medical grade tests. CPAP as an example of this. When somebody has any kind of CPAP anxiety, we'll ask them to desensitize themselves during the day and do something else while you have the PAP device on. And I think we do this in the dental space too, where if they have some kind of like anxiety around the dental appliance, or you just put the dental appliance in while you're watching television and distract your mind and not get focused on the sensation of what's in your mouth. The same thing can be done with these, like at least with the sleep and these multi-night tools. You just put it on your finger and then just sort of get used to the idea that something is on your finger for a couple of days. And then from there, one can potentially say, let's do a couple of nights of testing, and then let's see what kind of data we get. I think people have more performance anxiety if they have one shot. And that's been my personal experience. If they only have like one night of doing the test, then they have more anxiety around it. But if you tell them, hey, keep this for a week, do as many nights as you want to, test it out, the level of anxiety tends to go down. If you look at what the American Academy recommends is to not do a home sleep test to rule in or rule out obstructive sleep apnea, but it can still be useful information to have to understand the health of the sleep of that child. It is sometimes challenging to get good quality data. Many times, like at least in my experience, sometimes the rings fall off, and we've done, sometimes we'll ask the parents to tape it on their finger, put it on the toe, and then put their socks on, or put it on their finger and put a sock on. Those are sort of like things that sometimes can work. And, if you do this 7-10 times, for maybe a week or so, at least one of those days you will get good data. About bedwetting. So nocturnal enuresis is not something that happens every single day. It's not necessary for one to identify the timing of the nocturnal enuresis and the timing of the apneic event. That will not necessarily always be the case. It's more of getting just an idea of what is this person's sleep like, getting a good history. That do they have history of someone who may have sleep disorder breathing, mouth breather, tonsils, are they enlarged? Are they able to breathe through their nose? Do they have that craniofacial appearance? Like they call it an adenoid face, where mouth is kind of elongated. So I would treat it more from like a craniofacial development standpoint if you have evidence of that, but not necessarily focus on the outcome of fixing the nocturnal enuresis or fixing the sleep. I would just, from like a craniofacial dental standpoint, my thoughts would be to just focus on a healthy craniofacial development and not necessarily dabble too much into the sleep side of things. But it can be useful though, if you can get good data. In the Bay Area, I think you guys are blessed in the sense that there's a lot of good institutions. Stanford is amazing. and UCSF is also top of the line. So either one of those institutions, I would just refer them to their sleep department there, and whoever is like the expert for that specific problem, they can evaluate them in-house to see what would be the best way to take care of them. One thing to be mindful of is that if you look at the distribution of sleep stages across age, there's less deep sleep as we get older as compared to if we are younger. So these targets or these goals of stable sleep are very age dependent. So an older person, biologically, they typically cannot produce a larger amount of N3 or so. First of all, N3 and stable sleep are sort of synonymous. Stable sleep is like a healthy deep sleep during non-REM sleep. Okay. And the amount of deep sleep is specific to that person's age. So as one gets older, there will be less deep sleep. And to have healthy deep sleep, one's sleep needs to be hopefully free of disease. And when we think about diseases, it needs to be free of like obstructive sleep apnea, sleep disorder breathing. It needs to be free of restless legs, PLMs, and other influencers of fragmentation or deep sleep are anxiety, stress, chronic pain, mental health issues. Medications can change the architecture of sleep. So, for example, tricyclic antidepressants, antipsychotics, all of these medications can change the architecture of one's sleep and cause one to have less deep sleep. So the easy things to do is really just to make sure that someone's sleep is free of disease. And that should be the primary goal. And then everything else will typically fall into place. And the target of deep sleep or stable sleep should be based off of that patient's age. And sometimes if somebody has horrible sleep apnea, insomnia, one cannot have them have the physiologic amounts of stable sleep. It's like a diabetic. You can address their A1C, you can try to improve their glucose profile, but one cannot necessarily reverse the microvascular changes that happen to people who are diabetics. The context is a lot, and also understanding what are some of the other comorbidities as one tries to shoot for those targets. Insomnia historically has always been a clinical diagnosis. If one looks at the American Academy of Sleep Medicine guidelines, the definition of insomnia is very clinical, based off of nighttime symptoms, daytime symptoms, and their perception of sleep. One thing that is sort of ignored in those guidelines is that, or that definition is that almost 30% of people who have insomnia also have some degree of sleep disorder breathing. And if the goal becomes to help somebody fix their insomnia, one has to have a multimodal approach and also fix obstructive sleep apnea while addressing the insomnia. So a sleep test plays a very pivotal role in understanding what's happening to someone's. If they have obstructive sleep apnea, the only way to identify that is with a sleep test. So sleep tests are very useful even in the situation of insomnia, but it does not make the diagnosis of insomnia. It just allows us to rule out, does this person have, and I'm referring to home sleep testing. It allows us to rule out, do they have obstructive sleep apnea? Other times, insomnia, in the setting of insomnia, maybe an in-lab test can be useful, because another very common cause of at least sleep onset insomnia is restless legs, periodic limb movements that can happen. And so that can be very useful. But a sleep test can give us at least, and I'll use sleep image as an example, because it gives us sleep quality and it gives us stable sleep. It gives us some insights into what is the overall health of that individual's sleep. The sleep test is useful for sure. And I'll use the example of like cardiology as an example. The prevalence of sleep disorders, whether insomnia or sleep apnea combined, about 60% of the population in a cardiology clinic typically has some degree of sleep disorder breathing and or insomnia. So and we know that addressing at least moderate to severe sleep apnea improves comorbidities. It can reduce hospital readmissions. It can improve the recurrence of AFib if they have had an ablation or a cardioversion. It reduces the readmissions of the hospital if they have congestive heart failure. That's in the cardiac space. In the pulmonary space, people who have comorbid COPD with obstructive sleep apnea, if you treat these people if you treat their obstructive sleep apnea, the risk of reoccurrence or COPD exacerbations goes down. So addressing sleep disorder breathing and insomnia is sleep is one of these things that it's tangentially related to almost all fields of medicine. In the psychiatric population, anxiety, depression, bipolar disease, if that is unstable, sleep will typically fall apart. In the cardiac cohort we just talked about, in the pulmonary cohort, that's true as well. In like the endocrine cohort, we get so many patients nowadays who have hypotestosteronism or difficult to control diabetes, who have thyroid swings that are just difficult to control. So addressing sleep sets the foundation for at least that is one thing that has been addressed, ruled out, and then the specialist can do what they need to do. So sleep is tangentially related to so many different fields of medicine that it's actually very easy to incorporate this into that conversation. The way that it works, and so I'll feel free to chime in, is we're a virtual care platform helping people perfect their sleep. That's really what we strive to do. And we are test agnostic and treatment agnostic. And we want to do whatever we can to help people have the best possible outcomes. And what we've learned is the way to do that is have a comprehensive 1-hour visit to really understand what's going on. We'll mail patients a home sleep test. We'll have them use it for multiple nights. By getting 7 to 10 nights of data, it allows us to really personalize and understand what is happening to your sleep over time. And then on a follow-up visit, we'll go over the results. We'll do a screen share. We'll share with you what your sleep looks like. And based off of your preferences, recommendations, what we see on the data, we can help come up with a plan. If it's insomnia, we have a CBTI program that we can help you with. If somebody has sleep disorder breathing, we can prescribe a CPAP, ship it to your home. We'll build, your insurance can get billed for that. If you need a dental appliance, we have all these lovely dentists in our network and that are growing that we can refer you to, a dentist in the zip code. If a home sleep test is not helpful or diagnostic, we have more comprehensive tests. It's called the level 2 test that we can mail to your home that you can do that'll allow us to get a very detailed understanding of what's going on. If we need to refer you to a lab, we will be happy to do that so that you can go get an in-lab sleep test done. And our goal is that during your patient journey of trying to find what would eventually end up to be your sleep stack, we want to help coordinate all of your care. We want people to have a magical experience.